everyone. We are here in Las Vegas at the HFMA annual conference, the last day. Everything's wrapping up. I am joined with Brad Gingerich, VP of Payors Strategy here at Ensemble. Thank you so much for being here, Brad.
My pleasure, Kendall.
So you just presented here about an hour ago with Montecor Mercy Health on leveling the playing field with payers. It was really a packed house, which I think is a true testament to the issues that everyone here is facing right now. What is concerning you most when it comes to the relationships between the providers, the payers, and even the patients?
It's a great question, Kendall. So I've given this a lot of thought. This is something that kind of eats at me because we currently have a disconnect in healthcare in the way it works today. Let's take your typical insurance company. They typically have multiple products. They'll have a Medicare Advantage plan, they'll have a Medicaid product, and a commercial product. 3 different products, all funded differently, different margins to the payer. What's unique about this situation, though, is on the commercial product, approximately 80% of all those claims are funded directly by employers, self-funded employers, which means at the end of the day, the insurance company is not actually footing the bill on those claims. The actual fiduciary is the employer in most cases. So that creates a bit of a disconnect because the funding source isn't coming from the insurance company. So when we're engaged in negotiations, to an extent, at least for the commercial products, the payers are negotiating on behalf of their clients' employers. Well, that creates a bit of a conflict because when we engage in our negotiations, we're looking to typically discuss all of the products. So with a large payer who has all of these, we may be engaged in a negotiation for their commercial, their Medicare, and their Medicaid product. So we'll go to that payer and we'll be, let's say, pursuing an increase on the Medicare Advantage plan. And whether it's an actual rate increase or we're trying to pursue tighter language to avoid denials and leakage, whatever the case may be, we're pursuing that with the Medicare plan. And just as a side note, today, these Medicare plans are receiving around 102% of the Medicare rate from CMS. They're turning around and paying contracted providers in aggregate around 90, 95% on the better end. And so that spread, that differential of 10 to 12% is really all margin to an insurance company. So on the Medicare Advantage side, that's what we as providers are trying to pull back from. We're trying to get that reimbursement back closer to the Medicare rate, closer to 100% of Medicare. And so when we go into these negotiations with the payer and we draw a hard line on that Medicare product, the payers never budge. They might give an increase, and you might see as high as, say, 105% of Medicare rate on paper, but after all the denials, after they pay observation as opposed to an inpatient DRG, you're still pulling down well less than 100%. So you try to raise these issues with the payer in a negotiation, and you try to solve for them. Well, at the end of the day, what you actually get from the payer is a substantial increase on the commercial product. And they provide that as a way to pacify you on your concerns on the Medicare Advantage. And so what that effectively does is it shifts the responsibility, the financial burden back to the self-funded employers. Because again, I'm going to the payer saying I need a 10% increase on my Medicare Advantage. I'm not being paid enough today, I'm already not meeting costs. And say, oh yeah, that's great. Park it over here. Let's look at these commercial rates. I'm paying you today 250% of Medicare. How about we juice that up to 270? Will that satisfy you across the board? And we as providers say, well, you know what, we're just looking at the total bottom line. And so when I look at it all that way in aggregate, it does solve for my needs, and we agree. And Medicare stays where it always was. The insurance company continues to make a healthy profit on the Medicare. And what happens is those self-funded employers, hospitals as well, they're typically the largest employer in every community they're in, and they are self-funded as well, they end up subsidizing that insurance company profits. So their commercial rate gets increased. Again, it's not the insurance company who's funding the check. They're basically giving the due to the employer to fund the claim. And so the employer is subsidizing those profits, is creating an environment where commercial rates continue to increase. Medicare rates stay stagnant to the extent Medicare doesn't actually increase them, but they're not going up in terms of your negotiated rates. And so you continue to get a situation where commercial just outpaces everything else. So today, commercial insurance is 2.5 to 3 times Medicare reimbursement on any patient. But what I can tell you is it costs far less to treat a commercially insured patient than a Medicare patient. Why? Because of the age difference. Your commercially insured, these are working individuals, they're not Medicare eligible yet. It is very less costly to treat a younger individual than it is an older. There's just different comorbidities and situations you have to account for. And so when you think of it that way, my lowest cost patients are now paying the most, and employers are really the ones making this happen. And I say that loosely because providers, we do have culpability in this. We are the ones that are saying at the end of the day, I'll agree to that substantial commercial increase because I need the increase no matter where it comes from. And there's too much resistance from the payer on the Medicare side. And so we're stuck. And so again, it creates a situation where the commercial, they just continue to grow at a unsustainable pace. And again, our self-funded employers are subsidizing the insurance company's profits in this form. And that's rightly so. Employers are concerned about the cost of healthcare increasing every year, but it's not because their employees are any sicker. It's because the insurance companies are spending their dollars in a frivolous manner to protect their own bottom line. And so, yeah, I've given a lot of thought. No immediate easy solution on this one, but I think we have to really stand our ground on the Medicare, on the Medicaid products, and quit looking to the self-funded employers and the commercial products to subsidize our bottom line.
I know you just said there's no easy solution. I want to talk a little bit about how you on a daily basis and Ensemble as well are working with our providers throughout these negotiations and essentially to ensure that they're getting paid what they're owed.
Yeah, so it's kind of a two-prong approach. One is the negotiation. That's what gets the majority of the attention. That's what's exciting. That's what hits the press. There's potential termination, or this provider is asking for a double-digit increase, and insurance companies love to put that in the news because it looks unreasonable to ask for an increase that actually keeps pace with inflation. So that's what gets all the attention, but really the day-to-day where the magic actually happens, believe it or not, is in payer performance. And that's enforcing the existing contracts. So contracts are negotiated typically once every 3 or 4 years. So while it gets all the fanfare and attention, it's really not the day-to-day. The day-to-day is making sure the payers are paying the claims, making sure the denial rates are staying under control, make sure they're not abusing things like request of information and constantly pushing down thresholds such that every single claim you bill, whether inpatient or outpatient, now requires additional documentation as a contingency for payment. And so going back to the payer and saying the burdens and the hoops you're requiring us to jump through just to get the claim paid is no longer reasonable. We can't tolerate this any longer, and we need relief. And that can take a lot of forms. It can be AR projects, it can be full-on claim settlements, a lot of different ways to solve the problem, and also a lot of different methods to bring it to the attention of the payer as well. And that can range from dispute resolution within the contract, litigation, legal strategies such as taking a payer to court and suing them if your contract or the state law allows, arbitration as well. So there's a lot of different venues and ways to raise these issues. It's very payer specific. Some payers we have defined tactics, other payers you have to do the research and figure out what's going to be most effective or draw from your historical outcomes. But the day-to-day, again, it's really the payer performance management and less of the actual negotiation component.
You talked a little bit about the attention that a lot of these contract negotiations are getting, particularly in the media. What would you say to a provider who is maybe a little concerned about that? They don't want that media attention. They don't want to, for lack of a better term, fight this in the media.
Yeah, that's a great question. I hear that quite a bit from providers. They are intimidated or just reluctant to really take this into the public sphere. What I'll say to them is the only person more afraid of that happening is the payer. The payers are extremely concerned about optics. The last thing they want is a negotiation to spill out into the public arena. Payers do not have the greatest reputation. Providers do. Providers are open at 2 a.m. on a Sunday when your child has an ear infection. They are there for you. You're not going to get someone on the phone at the insurance company at that time. And so understand that and lean into it. Trust that your community supports your hospital. They are not supporting the big bad insurance company. So don't worry so much about that. Be matter of fact in your communication campaign. Make it clear why you're seeking these increases. It's not a matter of greed, it's a matter of necessity. Inflation is, coming out of COVID, I don't even want to give any time speaking to it. We all know it. It's a foregone conclusion. Hospitals have to do something to make their ends meet, and it's incumbent on them to do exactly that through negotiations.
You're very passionate about this topic. I have an interesting question for you. You're working with providers day in and day out. Would you ever consider going to work for a payer?
Oh gosh. No, and here's why. I think of payers like I think of the dentist. No one loves a dentist. I hate to say it. They provide a service much needed. Where would we be without our dentist? But who's excited about going to see the dentist? No one. I don't want to be in that role in the form of a payer. You only call the payer when there's a problem or when you need something, right? And so I don't want to be in that situation where I'm just always taking. I want to be regarded as providing value and a benefit to everyone. So I don't think I'd be comfortable in that world on that side. And the only other thing I would say is, in my role, despite the size of Ensemble and the leverage that we wield, still, if you take any one of our clients individually, it's still very much a David versus Goliath fight. And I find a lot of purpose in that. It's very rewarding to be the underdog and still have opportunities to come out on top. Not just from my own personal competitive side, but taking a look back at that community health system that we just helped, who did not have any leverage or clout with a national publicly traded for-profit insurance company. They don't have the ability to get to the C-suite. They don't have the tactics or the leverage. And so being able to bring that to them and help them is something that really gives me a lot of satisfaction that I could never imagine being able to get on the payer side.
That's great, and you brought up purpose, the purpose behind what we do at Ensemble. And I want to talk a little bit about the patients throughout these negotiations. What impact is this having on them?
Oh, it's incredible. And, it's unfortunate to say, but there's times that we actually have to utilize patients and mobilize them in the process. Negotiation strategy can take a grassroots kind of process and campaign, and at times we need to somewhat canvass the community and leverage their voice and encourage them through a call to action to reach out to your payer and tell them why this impacts you if they're not able to secure a new agreement. Or if it's foregone conclusion that we're not going to be able to reach agreement, we have to work with those patients to ensure their access to care. So what that means is, in the case of a Medicare Advantage or managed Medicaid, that means potentially moving that patient over to a plan that we still participate with, or at least empowering them to do so. So giving them the tools, connecting them to the broker network so they can make a change during open enrollment if they need to on their MA plan, or if it's a Medicaid product, there may be an opportunity for a just cause change mid-year, things like that. So the patients, unfortunately, at times do get pulled into the middle. We do our best to try to mitigate any of that impact to them. And again, at times, we actually have to utilize them as an asset to help further our mission, which again, it's a means to an end, and that end being keeping the hospital in network at rates that are going to allow it to be solvent well into the future.
Absolutely. Well, thank you so much, Brad. Thank you for sharing your insights. We appreciate your time.
My pleasure. Thanks.